Hello, everyone, and thank you for joining us today. For those of you who do not know me, I'm Jessica Foley, Chief Science Officer for the Focused Ultrasound Foundation. The Focused Ultrasound Foundation and the Children's Tumor Foundation are thrilled to have you join us today for a panel discussion exploring focused ultrasound and its potential for neurofibromatosis treatment. Today, you'll hear 4 brief presentations from our experts who I will introduce shortly. They will highlight the current challenges in neurofibromatosis type 2 treatment and the potential of focused ultrasound to become a versatile clinical tool to treat a wide range of medical disorders with a particular emphasis on focused ultrasound enhanced drug delivery techniques. For the subsequent discussion and Q&A, the panel will begin to brainstorm how focused ultrasound may benefit NF2 patients. And we'll also allow plenty of time for questions from all of you online. So before we get started, just a few technical items. If your connection is lost, please simply log in again through the link you received when you registered. You'll receive a link to a recording of the webinar as well. And if you'd like to ask a question, please submit it at any time via the Q&A function at the bottom of your screen. We'll collect these questions and answer as many as possible during the audience Q&A portion of our panel discussion. And now to introduce our panelists. First up is Dr. Michel Calamaridis, Professor of Neurosurgery at Pitié-Salpêtrière Hospital in Paris, France. He specializes in vestibular schwannoma and meningioma surgery. Next will be Dr. Airong Kim, Associate Professor of Pediatrics and a solid tumors attending in the Oncology Division at Children's National Hospital in Washington, D.C. Her research is focused on the development of novel therapeutics for pediatric cancer, sarcomas, and NF1-associated tumors. Then we'll hear from Dr. Nathan McDonald, Research Associate at Brigham and Women's Hospital and a Professor of Radiology at Harvard Medical School. His research has focused on brain applications, drug delivery, and neurodegenerative diseases. And finally, we'll hear from Dr. Tyrone Porter, a professor of biomedical engineering at the University of Texas at Austin. His work has explored the use of ultrasound for non-invasive ablation of solid tumors and triggering drug release from stimuli-responsive nanocarriers. So now let's get started.
Okay, NF2 is a rare disease characterized by bilateral vestibular schwannoma in almost all the NF2 patients, meningioma in half patients, and spinal tumors. You can get schwannoma of every size, small, very large. And what is very interesting, when you are dealing with tumor in an NF2 patient, in fact, you have to treat a very frequent tumor type, which is meningioma and schwannoma. Meningioma and schwannoma represent 40% of the primitive tumor of the central nervous system. So it's very frequent for a neurosurgeon to treat meningioma and vestibular schwannoma, sporadic. In AF2, the difficulty is to treat all the tumor in the same patient. I will start with vestibular schwannoma. I think that surgery is needed for very large vestibular schwannoma on the first side when you have clinical brainstem compression. This is an example of a young NF2 patient with a large vestibular schwannoma on the left side and on the right. And you see, when you start the tumor through a retrosimulated approach, you will face the cerebellum and the tumor. This is a petrous bone. And at the beginning, you see nothing. You have to debulk, and then you will see the 5th nerve, the 7th nerve, the 8th, and the lower cranial nerve. So all the difficulty of the surgery is to preserve all the cranial nerve around the vestibular schwannoma. And you have to remove piecemeal the tumor. This is at the end of the tumor removal, and you can see all the cranial nerve. And it's crucial for an NF2 patient to preserve the facial nerve function, and if possible, the cochlear nerve function, hearing, because without cochlear nerve, the patient is deaf. Other example of very large vestibular schwannoma, you see an example of kissing vestibular schwannoma with a very thin brain stem. So in such case, we have to remove one tumor and maybe the other. So it's difficult to preserve the facial nerve function, and when you have experience, you can preserve the facial nerve function in 80% of NF2 patients. Sometimes you have to leave a small piece and treat by gamma knife. It's very difficult to preserve the hearing function when you have to remove a very large vestibular schwannoma. And it's crucial to preserve the lower cranial nerve function to avoid swallowing difficulties. Sometimes you can only debulk tumor. It's a second side with a facial nerve palsy on the left side. And you see in this case, we decide to make a debulking on the second side schwannoma just to preserve the hearing and the facial function. Now with very small schwannoma in NF2 is another story. You have many options. You can observe small schwannoma in NF2 patient because you need to know the natural history of every tumor. So observation is the best solution in NF2 patient with stable schwannoma. Other options are internal auditory meatus decompression. When you have hearing loss with a stable, you can remove all the bone and open the dura without touching the tumor. Other option is radiosurgery for growing small schwannoma. And the last option is microsurgery to remove growing schwannoma. Two examples of small growing schwannoma you see on the right side, this small schwannoma, and over the years grows. We remove finally this tumor through a retrosigmoid approach with a total removal and hearing and facial nerve preservation. Another example of small schwannoma removed through a middle fossa approach. But now, 10 years ago, this publication in the New England Journal of Medicine by the MGH team changed everything. Now you have medical option. And this team published the interest of bevacizumab in NF2 patients. Bevacizumab is a VEGF antibody that can block the vascularization of the tumors. And they show that you can decrease the size of the tumor, but you can improve hearing, which is the only option for NF2 patient. And you see, you can improve hearing in 1/3 of NF2 patient. So it's very useful. And we use now bevacizumab for many patients. 3 examples of patients with large vestibular schwannoma on the second side treated by bevacizumab, and you can see nicely the shrinkage of the tumor. These are the 3 best cases in our center. All the cases were associated with hearing improvement on the side of the vestibular schwannoma. And you see, this is an example. So many schwannoma are stable under treatment. You can have shrinkage, and you have some failure, especially in young NF2 patients with very fast-growing schwannoma. There are other options. We tested everolimus, and you can see all the options tested in NF2 patients. There are 2 trials in development, one by the DoD NF consortium with crizotinib for growing vestibular schwannoma, and the other by the CTF Intuited NF2 using the briquetinib. So in these trials, you will include patients with growing vestibular schwannoma. Meningioma. Meningioma is the second type tumor in NF2 patient, and you can see in these 2 MRI very large meningioma on the forks. So you see this patient with headache, and you see this is meningioma. So meningioma can present with headache, with seizure, or with deficit. When you have a meningioma in pushing eloquent area, you can have a deficit on the hand or to speak. We analyze a series of NF2 patients with meningioma, and you see all the meningioma are mostly located on the surface, on the convexity, and sometimes on the forks and the tentorium, which are the dura mater separating the hemisphere. So you see more than 2/3 of meningioma are located on the surface. One quarter of meningioma are on the skull base. And when the patient are presenting meningioma, the mean number of meningioma per patient is 3, but they can have many meningioma with 30% presenting with more than 7 meningiomas. But in fact, only few of the meningioma will grow. Example of stable meningioma over years. And these 2 meningioma were in fact growing. And we had to remove these 2 meningiomas. So when you follow on a long-term NF2 patient, in fact, 2/3 of meningioma will not grow, and you don't need surgery. But 10% of meningioma will grow very fast, more than 4 millimeters a year. The mean growth rate is 1.5 millimeters a year. And when you remove the meningioma, 1/3 is grade 2 or grade 3. Another way to show tumor growth in this new series, and you see that 70% of meningioma will have a rapid growth, more than 2 centimeters cubed a year. And you can predict using a classification. So now we are using this classification to predict from the beginning the risk of tumor growth based on diameter classification, edema, and T2 signal. Example of a meningioma in NF2 patient. In this young NF2 patient, we decided to remove this growing skull-based meningioma compressing the brainstem. And a few months later, the patient was fine, but with a seizure and deficit on the right leg. And you can see this very fast growing meningioma. So we had to remove the meningioma, and the patient was fine. And you see on T2, the edema associated with the growth of the meningioma, and in such case, you can get seizure and difficulty to remove the meningioma because there is no interface between the meningioma and the brain. The last tumor in NF2 patients are spinal tumors. You can get meningioma compressing the spinal cord, or schwannoma, raising for the nerve, compressing again the spinal cord. And this is an example of a bilateral C4 schwannoma compressing the spinal cord. So it's very tricky to remove such schwannoma because the spinal cord is posterior, so it's very difficult. The last tumor type in NF2 patient is ependymoma. It's an intramedullary tumor, it's a benign, grade 2 or grade 3, associated with cyst. And you see in this patient, the patient presented with walking difficulties, swallowing difficulties because of the cyst going to the brainstem. And the treatment was to remove this ependymoma, and the patient was fine after surgery. The last tumor type in NF2 patients are peripheral schwannomas. They can be everywhere in the body, and sometimes they are not well located. So sometimes it's very difficult to remove such schwannoma, and you need expert. This is an example of a deep-seated schwannoma, very close to large vessels. This schwannoma is located in the brachial plexus. So you have to preserve all this branch to preserve hearing function. And the last example is schwannoma in the end. You see this schwannoma is painful. This is an example of body MRI, and you can see multiple schwannoma in the body of the patient. Most are asymptomatic, but sometimes they can be painful, and the patient needs surgery. So, just to open the discussion on the interest option for IFU in NF2 tumors, I think that for me, you can discuss tumor debulking for large vestibular schwannoma, but you have to keep in mind all the cranial nerve around the schwannoma. So I think that you can debulk the center of the schwannoma to help the surgery, or maybe to stop tumor growth. The other target could be the growing meningiomas, because they can be small, they can be in non-eloquent areas, so you can have small edema without trouble. But the difficulty is that most of the meningioma are just under the skull. So it's maybe difficult with focal ultrasound to treat this type of tumor. And the last are the peripheral schwannoma. Maybe you can treat when they are painful. So these are the possibility to debulk, I would say, the tumor. The last option or possibility we can discuss is to open the barriers to improve the medical treatment effect. For the moment, we are using only cytostatic drug, bevacizumab and others, because we don't want to have side effects for the NF2 patient. So NF2 patient, it's a benign disease, I would say. So you can give drug like for patients with cancer. So if you can open not the blood-brain barrier, because meningioma and schwannoma are not inside the blood-brain barrier, but if you can open the meningeal brain barrier, maybe you can increase the effect of the cytotoxic drug, and you can reduce the number of bevacizumab injection, and maybe you can be more optimist and you can use cytotoxic drug to treat and to target the drug to the tumors. So I think that these are two very interesting options that we can discuss using IFU for NF2 tumors. Thank you.
Hi, I'm Nathan McDonald. I'd like to thank the Foundation for the opportunity to talk to you today. I'm a physicist and the head of the Focused Ultrasound Laboratory at Brigham and Women's Hospital in Boston. And I'm going to give a short overview of the current status of MR-guided focused ultrasound in the brain. So for those of you who aren't familiar with focused ultrasound, we take a transducer that's either geometrically focused or with a phased array, and we focus high intensity sound deep into the body, similar to how you can focus light. And as the ultrasound is absorbed, it's converted, the energy absorption can be used in a number of different ways for different therapies. And these can be divided into two main categories, thermal therapies and non-thermal therapies. With thermal therapies, the one you may be most familiar with is using focused ultrasound for thermal ablation, but it's also being tested for enhancing radiation and chemotherapy, and there are heat-activated drugs that you can trigger their release at the focal point. For non-thermal therapies, there are a number of different ways we can do this. A lot of them use microbubbles to potentiate the effects of the ultrasound. And people have looked at this to enhance drug delivery, to do mechanical ablation. They've developed drugs that are pressure activated, so you can, again, release them at the focus. And then there's a number of different therapies that people have looked at this, including vessel occlusion, loss in clots for stroke, and there's a lot of interest in using ultrasound for neuromodulation. This is not a new technology. This has been around since the 40s. And in the 1960s, there are actually pretty extensive clinical trials using focused ultrasound, but it didn't catch on. And the main reasons it didn't catch on were first, in the brain at least, it required a craniotomy, so it was an invasive procedure. And second, since it's a non-invasive therapy, you can't see what we're doing. So until we had imaging methods that we could use to sort of guide and monitor the procedure, it was very challenging to use. So with the advent of MRI and ultrasound imaging, this has really regained interest over the last couple decades. I'm going to talk mostly about the brain today, but there are a number of systems used throughout the body. These are just some of the clinical MR-guided systems for fibroid and prostate and bone tumors, so that there's a huge amount of work being done outside the brain. In the brain, this is what the current system looks like. This is a device made by a company called Insightec out of Israel. And it uses a number of tricks to allow us to focus through the intact skull without having to do a craniotomy. The problem with the bone is that it gets hot when you apply ultrasound to it, so it's highly absorbing compared to soft tissue. And to get around that, they've developed a helmet-shaped transducer that distributes the energy over a large area of the skull and uses a lower frequency, and then with active cooling, we can get through the skull and get a high-intensity focus that'll allow us to do thermal ablation. The other problem with the skull is that it distorts the ultrasound field, so it acts like a defocusing lens. And the way they get around that is to use a phased array. This is an example of the first 32 cases of at our hospital where we treated for essential tremor. And you can see that there's a huge range in these are maps of the attenuation. And indeed, the energy that we need to get an ablation in the brain varies by more than an order of magnitude. And you can see that there's a lot of variability from patient to patient. So we really need to have a monitoring, because we don't really know what the intensity is until we start the treatment. And we need to be able to correct for these aberrations. The way we do this is to use a phased array. So instead of using just a single element focused transducer, it's an array of hundreds or thousands of elements. And that allows us to do certain things such as steer the focal point. We can shape the focal area or create multiple focal spots. But in the brain, the important thing is that we can correct for aberrations induced by the bone. And we can do this by acquiring a CT scan of the patient before the treatment. And we use acoustic models to predict what the distortion is for each element. And then we apply a phase correction so we can restore the focus. With transcranial ablation, it's currently FDA approved for the treatment of essential tremor and for tremor-dominant Parkinson's disease. And when we do this inside of a 3 Tesla MRI scanner. And we acquire special MR sequences that allow us to actually map the temperature. So here we can see in this image here, this is the helmet of the transducer. And you can see this bright spot here is where the focus is. This is where it's getting hot. And we usually heat it to about 60 degrees Celsius. And for this treatment, we're ablating a small target in the thalamus. And this is a treatment for a tremor. One of the limitations of this system, or the technology right now for thermal ablation, is that we can only target a fairly limited area. This may be a little bit out of date, but it's fairly close. This is a map provided by Inside Tech that shows where they can target in the brain. And again, it varies quite a bit from patient to patient. And so right now we're limited to areas deep and central in the brain, and they're looking at thalamotomies or targets in the globus pallidus or in the internal capsule. But things like epilepsy are just outside of where we can reach right now. Maybe with some technical developments, we'll be able to target there. It's also a fairly complicated and time-consuming procedure. And the reason that we're limited to this area away from the bone is because of skull heating. As we start to go more off axis, the heating of the bone increases, and we can't do the trick anymore of distributing the energy. So moving on to different therapies. So a lot of the therapies that are involved with that don't use heat as the main mechanism uses microbubbles. And a lot of them that we use, we introduce the microbubbles intravenously. And this is done with ultrasound imaging contrast agents. And these bubbles really potentiate the effects of the ultrasound directly on the vessel walls. And there's a number of physical interactions that we can use to modify or damage the blood vessels. So if we just use sort of a stable oscillation, we found that we can modify vascular barriers. So the blood-brain barriers where we've been looking at. And if you want to drive them a bit higher, we can use these bubbles to enhance ablation. So one of the things that's gotten a lot of interest is being able to temporarily disrupt the blood-brain barrier. And the blood-brain barrier generally protects the brain and does not allow substances that are in circulation to reach the brain. And about over 20 years ago now, we found that if we use very low power pulsed exposures combined with these imaging contrast agents, that we get a temporary opening of the blood-brain barrier that lasts for a few hours. And because this is using such a low power, we don't have the same problems we have with ablation, and we can use this anywhere in the brain. This is an interesting phenomena that we've observed, in that when we disrupt the barrier, we're not just opening up tight junctions, and we're not poking holes in the blood vessels. So we're widening the tight junctions, but we also trigger transcytotic vessels, and we also reduce drug efflux. This is just an example of electron microscopy showing delivery of an agent through the tight junction. And we also get these vesicles where we get active transport. When we go to higher levels, we start to get vessel damage. This is an interesting technique because it's completely drug neutral. And in preclinical models, we've looked at a variety of things, looking at simple contrast agents and chemotherapies that we've been looking at for brain tumors, antibody or targeted agents for something like Alzheimer's. This is an Alzheimer's mouse showing the plaques lighting up after we disrupt the barrier, or even large things such as cells. So here's as an example in a rat where we were giving neural precursor cells. This has reached the clinic, and this clinical translation has really been pioneered by the group led by Clara Heinonen, the late Todd Made Prize, and Nir Lipsman, where they've started doing these clinical trials. So this was one of the first cases they did, and this is now in clinical trials at multiple sites for delivering chemotherapy to brain tumors. And we're involved with one of those trials at Brigham, delivering temozolomide, and hopefully over the next year we'll be looking at delivering carboplatin. People have also indicated that the disruption itself could be therapeutic. So people have found that when, at least in Alzheimer's model mice, if you disrupt the barrier without any drug, you can actually clear amyloid. So this is also a potential therapy using just the BBB opening alone. And this is also now in clinical trials, again, started in Toronto, but now at multiple sites around the world. So this is very exciting, and will be interesting to see how this pans out. If we drive the bubbles a bit higher, we can actually achieve ablation pretty much anywhere in the brain would be possible by using these microbubbles, which again concentrate the ultrasound effects on the vasculature. And instead of cooking the tissue like we do with ablation, we get ablation via ischemia. So we're actually shutting down the blood vessels in the area to target. And again, the power requirements are much lower than what we have for thermal ablation. So this could potentially be used anywhere in the brain. And one of the things we've found that white matter is actually less sensitive to this technique, to its lower vascular density. These are some examples from rat studies looking at this. And this is a study from a few years ago where we tried this non-thermal ablation, and we ablated a volume in the rat right next to the optic tract. And we found that we could ablate there and did not get damage in the optic tract. And in a follow-up study, we were looking at doing sort of volumetric opening, and we found that over a very short period of time, just a few weeks, the tissue that we've ablated in the brain, here we did a target in the thalamus, is removed very quickly. And again, we found that we didn't see a lot of damage in the large white matter tracts. More recently, we've been exploring using the clinical device for this non-thermal ablation. And you could see even with a low frequency ultrasound device that we're using clinically for the BBB opening, we can get very precise the ablation in the brain, even in the tiny rat brain. Going forward, we also tested this, looking again at the skull base with this non-thermal ablation, and this was in a monkey model. And again, we were ablating targets very close to the optic tract successfully with the clinical device. So to summarize where we are now, the current status of focused ultrasound in the central nervous system, for thermal ablation, there is an FDA-approved and reimbursed treatment for essential tremor and tremor-dominant Parkinson's. And it's being investigated for other functional neurosurgery procedures, such as for neuropathic pain, obsessive compulsive disorder, depression, Parkinson's, and other areas. For drug delivery, blood-brain barrier opening has now started in clinical trials that have shown that it's feasible and safe, but we're waiting to see the efficacy trials on that. I didn't really discuss neuromodulation. It was a bit of out of the area of our what we're we're talking about today. But we've also seen clinical trials starting on this, and there's a number of applications starting soon. And this plot over here were just some sample images from the studies that we've done at Brigham over the last 20 years, looking at all the different ways that we've looked at using ultrasound in the central nervous system. So it's a very flexible technology with a lot of opportunities that could be of interest to this group. And with that, I'm going to stop. And again, thank you for the opportunity to talk to you today, and I'll be happy to take any questions.
So hello today, my name is Tyrone Porter. I am a professor of biomedical engineering at the University of Texas at Austin. And I'm going to touch on two different topics here. One is both are nanoparticle based, combining ultrasound with nanoparticles for cancer therapy. One is a pressure sensitive nanoparticle for some ablation work. And the other is a thermal sensitive or temperature sensitive nanoparticle for drug release. So here are the two topics. I'm going to start off with the pressure sensitive nanoparticles for the tumor ablation, which actually benefits and leverages some of the work that was discussed earlier. The idea here is to leverage cavitation or ultrasound driven microbubbles for treating brain cancer. And for obvious reasons, primary brain cancer is one of the most lethal forms of the disease. This is some of the work that my lab has been sort of spearheading and leading over the last couple of years. The mean survival time for primary brain cancer is approximately 14 months. This is largely for glioblastomas. And the standard of care is surgery, radiation, and chemotherapy, adjuvant chemotherapy. Thermal ablation is not ideal for brain cancer therapy due to the attenuation in the skull, and that can result in thermal damage at the brain surface. And so we've begun exploring this idea of using intravascular cavitation and testing the effects of that on brain tumor viability and growth. There are some hurdles to implementing a cavitation enhanced ablation in vivo. It's difficult to control and sustain the acoustic cavitation within solid tumors. The pressures required for that can be quite high. You can use people have used ultrasound contrast agents, which are stabilized microbubbles, as cavitation nuclei to enhance thermal ablation and other types of ablation. But these contrast agents have short circulation times, can impair or impede wave propagation, and that can lead to unwanted prefocal heating and thermal damage. So these hurdles have been addressed with the development of vaporizable fluorocarbon nanodroplets. And my lab has been one of the pioneers for these types of nanodroplets. The idea was pioneered actually at the University of Michigan. They started out with microdroplets in the earlier work, and this was by Krifkins and folks back in the late 90s and early 2000s. Using these perfluoropentane, which has a boiling point of about 27, 29 degrees in bulk. But upon emulsification, you can increase the boiling point to greater than 45 degrees Celsius. These droplets can be vaporized with a short acoustic pulse, and then those bubbles can be driven to cavitate using subsequent ultrasound pulses, and you can increase, and these bubbles will grow explosively and collapse, and the collapsing bubbles can then damage the blood vessels and also tissue. So we've been using or studying these droplets for treating brain tumors. And in this case, we've done some exploration just to confirm and to identify the pressures required for vaporization in brain blood vessels, in brain tumor blood vessels, as well as driving the bubbles to cavitate for an extended period of time. In our studies, we've used anywhere from 10 to 15 minutes to treat brain tumors that have been established in rat brains. And so these are some MR images. The top row is the cortical zone. So this is prefocal using these focused ultrasound transducers. These images are from the prefocal region inside the brain. The bottom of the second row is actually at the transducer focus. The left column is a case where we administer microbubbles just for comparison. And the right column is a case where we administer these fluorocarbon nanodroplets. We're able to successfully vaporize and drive the inertial cavitation. We're able to actually homogenize a region of the tumor at the focus of the transducer and avoiding any prefocal damage, which has been documented and reported for microbubbles. We also harvested these tumors, looked at H&E staining. We can identify live cells, live cancer cells, as well as dead cancer cells. The dead cancer cells are predominantly in the perimeter or the periphery of the tumors for the microbubbles. And in the case of the nano droplets, we actually successfully liquefied or homogenized the inner core and also achieved some depth in the perimeter as well. And so our ongoing studies right now, and we believe this is more of a non-thermal effect than the thermal effect, our ongoing studies right now are to look and see basically the survival of these animals after the treatment. So just real quick in summary, these droplets can be used to nucleate and sustain inertial cavitation, given that they can circulate for minutes up to hours. We can sustain that cavitation activity for a longer period of time than the microbubbles. And the sustained intravascular cavitation can be leveraged for focal ablation and destruction of brain tumors without the prefocal damage. And so we're looking forward to leverage that and build upon that in future studies. And so the second topic I want to touch on today is thermosensitive liposomes for delivery of anti-cancer agents, and actually using ultrasound as the heating source in order to trigger the drug release. So thermosensitive liposomes have been around for a number of decades. The main constituent for these thermosensitive liposomes is DPPC, has a phase transition temperature between 42 and 44 degrees Celsius. You can stabilize the liposomes by just adding some cholesterol. But there has been a number of studies and documented studies where these more traditional formulations have been used. They're quite stable, and you can use a variety of different types of heating sources in order to trigger release of drugs over 15, 20, or 30 minutes of heating. The problem here is that there is a fairly slow release kinetics, and as a result, prolonged heating is required. And so you do oftentimes need to heat for much longer than 15 minutes in order to successfully release more than 50% of the drugs. A very unique formulation that was introduced in the early 2000s incorporates a single fatty acid chain lysolipid, and that does actually tend to stabilize these grain boundaries and enhance the leakiness of the liposomes upon heating. And so you can actually end up releasing more than 50% of the encapsulated payload or drug in a matter of about a couple of minutes, compared to 15, 20, or 30 minutes required for the traditional thermosensitive liposomes. We have looked at this more closely and used ultrasound as, once again, the heating source because it can be applied non-invasively. You can also use MR thermometry in order to monitor the heating. And the idea here is to use ultrasound to heat non-invasively the liposomes, and the tissue is really what we're heating. Heat that to above 42 degrees Celsius, and that releases very rapidly the drug, particularly when we are using these lysolipid-containing liposomes. So they're considered low-temperature thermosensitive liposomes. And so once again, we can use MR thermometry. We can use that in order for feedback, which allows us to decide what ultrasound pulsing parameters to use in order to heat and hold the temperature at a desired point. In this case, 43 to 44 degrees Celsius for at least 5 minutes. And from our prior work and other published studies, we know that within that 5-minute heating time period, we can get significant release of a chemotherapeutic agent. Our work was done with doxorubicin, partly because it is very effective against a broad spectrum of cancers and malignancies, but also is fluorescent. And so we can actually take histological samples and then look for the distribution of the drug over, in the cases of temperature sensitive liposomes that have been heated to a desired temperature. And so as you can see here, we've been able to successfully release untreated is the top row. The second row is the traditional thermosensitive liposome, and the bottom is more the lysolipid containing. And you can notice that there is more drug, more doxorubicin that has been released in this bottom row when heating to 43 degrees for about 5 minutes compared to the more traditional formulation of these thermosensitive liposomes. We did some tests just to look at the response of tumors or tumor growth over some time period for different treatments. The leftmost here is untreated. This is free doxorubicin, which is proven to be effective, this one here. This here is drug treatment and growth for temperature-sensitive liposomes, more traditional formulation heated to 43 degrees Celsius. In this case is where we've used the isolipid-containing thermosensitive liposomes. We've had much more success with halting or delaying tumor growth using this formulation in combination with the ultrasound-mediated heating. So there are a number of cancer clinical trials that are ongoing or have been completed using these thermosensitive liposomes combined with ultrasound HIFU mediated heating. The Tardox, which is using the Thermodox, which is a lysolipid-containing liposome for liver cancer. That was in phase 1. It had some findings that were published in Lancet Oncology in 2018. Optima also uses Thermodox combined with radiofrequency ablation in unresectable hepatocellular carcinoma. And Dignity, which is once again using Thermodox, was combined with microwave hyperthermia for breast cancer recurrence in chest wall. So that was in a phase 1 or 2 clinical trial. So there are a number of studies that are using these lysolipid-containing liposomes that are commercially known as Thermodox. And so just in summary, nanoparticles can be designed to respond in a predictable manner to a pressure or temperature changes induced by ultrasound. The approach can be leveraged for non-invasive localized treatment of solid tumors and other lethal diseases. And with solid understanding of the fundamentals and generous serving of creativity, the possibilities are endless using this combination of these nanoparticles with ultrasound for cancer therapy. And I just want to acknowledge members of my group and funding sources, and I'm pretty sure there'll be time for questions later on. Thank you.
Today, I'll be discussing high-intensity focused ultrasound for pediatric tumors and tumor predisposition syndromes through the development of clinical trials for this device. A major goal of pediatric cancer medicine and novel therapy development is to identify potential targets with the goal of optimizing efficacy and decreasing toxicity. One of the prime and more common examples of this is precision medicine through genomic sequencing to identify actionable mutations. However, advances in imaging and tumor localization allows for non-invasive therapies and novel drug delivery mechanisms as a method for precision therapy as well. At Children's National, I belong to a multidisciplinary group called the Image-Guided Non-Invasive Therapeutic Energy, or IGNITE group. Our mission is to improve the quality of life and outcomes for pediatric patients through the development and clinical introduction of novel, minimally invasive and non-invasive surgery technologies and combination therapy approaches. Our approach is through the development of image-guided, high-intensity focused ultrasound, or HIFU, through targeted approaches to minimize side effects and increase efficacy. Advantages of MR HIFU are that it's primarily non-invasive, there is no radiation, allows for large volume ablation, and there's flexible control over heating applications, which allows it to be combined with other applications. It's been well tolerated in adults with minimal, minor, and reversible adverse effects, all of this which make it ideal for pediatric development. One of the first clinical trials we developed for pediatrics is the clinical trial of MR HIFU ablation for pediatric solid tumors. The primary objective of this was to identify the safety and tolerability of MR HIFU in children with relapsed or refractory primary or metastatic solid tumors, including desmoid tumors. We had a variety of secondary objectives as well, which is to preliminarily define tumor response, as well as evaluate changes in blood immune markers and quality of life patient-reported outcomes. Patient eligibility and imaging were reviewed by a multidisciplinary HIFU team, which included a team of anesthesiologists, oncologists, interventional radiologists, and surgeons, as well as our bioengineering team. A patient underwent HIFU ablation of the target lesion under sedation to a treatable volume maximum of a 4-hour treatment time, and this was to limit the total amount of sedation needed. The patient was followed for 14 days post-HIFU therapy to evaluate for any adverse events, and then subsequent treatment cycles were possible if the patient had additional target volumes or the target was incompletely ablated. So here is an example of the treatment from treatment planning to post-treatment imaging. So for here, we allowed to plan the treatment using T1 weighted MR. Here's the tumor and the tumor volume. During treatment and monitoring, we're able to look at the total dosing that was delivered through MR thermometry, as well as total thermal dose. And then subsequently, we can verify success through subtraction contrast enhanced MRI imaging to look at the portion of the tumor that was treated. Here is an example of one of our patients, again, that was treated on this study. Here is the transducer. Here is her tumor. Here is the amount of heat that's been applied, as well as the thermometry that was occurred. And here's the post-treatment verification and success. We had a total of 11 patients that were treated, a median age of 14 years. The majority of the diagnoses were sarcomas, including desmoid tumors, and the tumors were located in a variety of places. All these tumors were treated with standard therapy upfront, had failed, and had required multiple different types of prior treatment. A total of 17 HIFU treatments were given. 5 patients received more than 1 ablation treatment, and 2 treatments were not technically feasible. These were second treatments for 2 patients. The adverse events were primarily mild and reversible, mostly due to the local control effects, including edema, pain, and skin burn. 1 target lesion was completely ablated, but all others were only partially ablated due to the large irregular shape, heterogeneity, and infiltrative nature of these tumors. The median tumor volume was 267 mLs. So from this trial, we concluded that MR HIFU ablation of solid tumors in children, adolescents, and young adults appears to be safe and feasible. We have our tumor volumetrics, changes in PROs, and immune biomarker analysis that are pending. However, it indeed demonstrated multiple challenges to this approach, primarily in the inability for complete ablation, and mostly due to tumor location, size, due to artifacts, position next to vital structures, and patient positioning on the instrument itself. So this, in order to target some of these challenges, we had to think about what are other tumors that we can apply, and what are some combinations with smarter therapies that we can think about. So one of the approaches that we thought about was application of HIFU ablation for atypical neurofibromas or distinct nodular lesions in patients with NF1. And this was work primarily done by our former fellow, Caitlin Tidings, who is now a faculty member at Children's National this year. But atypical neurofibromas are pre-malignant lesions to malignant peripheral nerve sheath tumors, which are aggressive and highly lethal sarcomas in patients with neurofibromatosis type 1. Removal of these atypical neurofibromas, even suboptimal, may prevent transformation to MPNSTs. Atypical neurofibromas may appear as distinct nodular lesions on MR imaging, such as the example shown here, which kind of make it ideal for application of MR HIFU ablation. So what we planned was a retrospective review of imaging of patients with NF1 and distinct nodular lesions or atypical neurofibromas to determine by size, location, and imaging of whether MR HIFU ablation was feasible as a potential alternative to surgical resection. We demonstrated that we found 122 distinct nodular lesions in 26 patients, both at the NIH and Children's National. About 42% of these lesions were allowed to be completely ablated by MR HIFU, whereas about 22% could be partially ablated to greater than 50%. About 36% were not able to be ablated, not due to size, because the size was actually the same in patients that were able to be ablated or not ablated, but primarily due to limitations due to location close to skin surface or vital structures. So based on this work, we determined that MR HIFU is feasible in about 64% of distinct nodular lesions, but major limitations included proximity to vital structures, but that MR HIFU may be feasible as a non-invasive alternative to surgery for atypical neurofibromas or distinct nodular treatments. Future work in reliability and congruity in identification of DNLs, methods and designs, and MR HIFU simulation of these lesions are ongoing right now. We think there's a potential for clinical translation of this study in a phase 0 trial for atypical neurofibromas that will undergo resection to be treated with MR HIFU for histology post-resection. And this work is currently ongoing with Dr. Tidings. Another way to approach one of these challenges is combination with smarter therapies. So at Children's, we have a phase 1 trial of Thermodox, which is lysothermosensitive liposomal doxorubicin, and MR HIFU for pediatric solid tumors. LTLD is a heat-activated formulation of liposomal doxorubicin, which allows for release of systemically administered encapsulated doxorubicin with heating at about roughly 40 to 45 degrees Celsius, which is mild heating temperatures. This allows for rapid drug release in the heated target tumor vasculature. So as you can see here, at normal heat, we have stealth lysosomes where doxorubicin is not released. But upon heating, there's immediate release of liposomal release of drug to allow for high concentrations of doxorubicin at the target, intended target with heating. In an LTLD with MR HIFU in a rabbit VX2 model demonstrates 7.6 greater tumor drug delivery than doxorubicin alone. And as you can see in this histology, there is much greater concentration of doxorubicin with LTLD and HIFU versus pre-doxorubicin or LTLD alone. LTLD has been evaluated in hepatocellular carcinoma with radiofrequency ablation and recurrent chest wall breast cancer with microwave heating. There is also a phase 1 study of LTLD with ultrasound-guided HIFU in liver tumors, where 50 milligrams per meter squared dose of LTLD was followed by ultrasound-guided HIFU. It demonstrated 3.7 times increase in doxorubicin concentrations in intratumoral biopsies. About 730 patients have been treated with thermodox, and primarily dose-limiting toxicities is similar to that of liposomal doxorubicin, which is myelosuppression and rash, erythema, or induration in superficial cancers. Our experimental design is LTLD is given over 30 minutes on day 1, followed by MR HIFU. On day 2, a myeloid growth factor is given, and then patients are followed as an outpatient setting for 21 days, and then end of cycle evaluations occurs. Patients can get subsequent treatments if they have additional target lesions, and the initial treatment was well tolerated. This is an example of one of the patients that were treated on this trial with osteosarcoma that was metastatic, recurrent, and painful. Here you can see his large scapular lesion, and this was the pre-treatment work that we did on his MRI. These are the treatment cells that were placed on this tumor. And then this is the post-treatment effect that you can see there. A good portion of the tumor was ablated. However, there are portions that were unable to be ablated, and this is the portion that we hope are affected and treated with the thermodox. This trial is currently ongoing and open to enrollment still. So in conclusion, HIFU is non-invasive, non-ionizing, and has flexible bioeffects with the ability to combine with multiple types of therapies, coupled with precision imaging, makes it extremely attractive as a potential therapy for difficult to treat tumors. We have ongoing preclinical and clinical applications of MR HIFU, including treatment with immunotherapy and other applications that we have ongoing that have the potential to change treatment paradigms for pediatric tumors and tumor predisposition syndromes. I'd like to thank our IGNITE team, including the clinical scientists, the biomedical scientists, our collaborators at the NIH, Cincinnati's, our industry collaborators, as well as our funding mechanisms. Thank you.
Thank you all. Let's see, I think we're all gonna sign on here now. So thanks to all of those presenters for the excellent presentations. And quickly, before we move into our discussion and Q&A, Dr. Salvo La Rosa from the Children's Tumor Foundation would like to say a few words about putting this together and kind of what it means moving forward. Salvo?
Thank you. Can you hear me?
Yes.
Can you hear me? Okay. Well, first of all, thank you to all speakers and to Focused Ultrasound Foundation for organizing together with us this excellent webinar. I think I just want to thank all the participants that have been tuning in, since we really want to understand and open a dialogue for potential applicability of Focused Ultrasound's technology, especially to NF2, but in general to the field of neurofibromatosis. So this is the first step, this workshop and webinar. Eager to hear from the community, both from the Focused Ultrasounds community, but also from the neurofibromatosis community on ideas and proposals to use this technology to solve problems. The next step is a more open forum to be organized in the future. Or, if there are quite few ideas that you guys have in mind, and we may also think of a special request for applications to be launched as a result of all this collaboration. So I don't want to take much time out of the discussion. I think there was excellent points and a point of synergy between NF and focused ultrasound technology. So thank you, Jessica. Thank you, everyone. And let's move on the questions.
Great. So I have some questions prepared, but I'm also gonna take your questions from the audience as some of them come in. So first I'll start with one of the questions we received online from Dr. Porter. And that is the thermosensitive liposome release occurring in the vasculature in circulation, or is passive EPR uptake still required?
Both approaches have been tested. I know at Duke University, some years ago, they were actually triggering drug release from the circulating liposomes. And the work that I've done in partnership with Nathan, we did allow some time for the vast majority of the particles, the liposomes, to accumulate in the tumors and in order to release the drug. So the lysolipid can be used. You can heat the tumor to a point where you can trigger drug release from the circulating liposomes. So actually heating within a couple of minutes after administration of the liposomes. And that can be effective. There have been some studies reported documenting some success with that technique and that approach. Of course, there's a question, one could ask the question, how much of the drug actually then does penetrate into the tumor, how much remains in circulation, because now it's free doxorubicin, ends up downstream. Those are very valid questions, and I don't know if that has been thoroughly explored at this point, but both strategies have certainly been tried.
So I know for our study, the doxorubicin is, the thermodox is systemically given, and most of it is done through passive at the site of heating, but it's not 100% that it's only going to be localized to the site of the tumor where the tumor is heating. There is, as you know, because we see adverse effects in terms of myelosuppression. So there are off-target heatings. It's not 100% precise. That being said, just based on some of the animal data and from the TARDOC study, we know that the concentrations of doxorubicin is far greater in the tumor based on intramural biopsies rather than what you see outside. Have you given free liposomal doxorubicin that is not attached to a thermosensitive liposome? There are PK studies being done, although it's not exact because a lot of the PK that's done is through serum PKs and not only through tumors, but we do believe that the concentrations that you can achieve with thermodox are far greater than what you can be given had you given it a systemic liposomal doxorubicin alone. And you couldn't give those concentrations because of the limitations of myelosuppression if you were doing it alone.
I have a question for you. For meningioma, meningioma are particular tumor because they are vascularized by the external carotid artery. Sometimes you can embolize the tumor before surgery to reduce hemorrhage. So can you think that we can target the meningioma using injection through the external carotid artery and then treat by ultrasound? So you can target only not the brain, only the meninges. What do you think about this?
I do think that's a viable option because my sense here is that you're getting a localized injection.
Yeah.
And so I suspect you would get a much higher concentration. I think combined with the prior question, and I think Arang has touched on this a little bit, you can heat and you'll release drug from the circulating liposomes. You would not need, or it would not be required to wait until you have any type of accumulation. And this is in the brain, so you probably won't have very much accumulation anyway in terms of just the nanoparticles. I think that's a worthwhile idea to test and pursue.
So you know, Dr. Calamarides, you talked about the importance of preserving the cranial nerves and other nerves. Is that the biggest challenge or the primary challenge in treating NF2 patients, or are there other key challenges sort of factoring in as well, like drug treatment? Are there side effects of the primary drug treatments that are a major issue?
For vestibular schwannoma surgery, the goal is to preserve the cranial nerve, especially the cochlear nerve, to preserve hearing. So I think for vestibular schwannoma, yes. We are using now bevacizumab. And you know, with bevacizumab, you can have kidney side effects. So if you can concentrate the drug, because meningioma and vestibular schwannoma are benign tumor, and they are characterized by highly vascularization. So if you can target the vessels inside the tumors, I think it's good. I was very interested by the non-thermal ablation, because with such strategy, maybe only reducing the vasculature of the tumors could be interesting. Yeah.
Yeah, and that was sort of another question, was particularly, Nathan, you showed preservation of the optic nerve when you were doing that, in your non-thermal microvascular ablation study. Do you think that that similar kind of technique could be useful in, vestibular schwannoma or one of these tumors?
I think it could. I mean, the gray matter in the brain is very highly, very high vascular density. So we have a lot of bubbles there when we inject the bubbles. And I don't know much about there can be challenges in tumors depending on how vascular they are. And how
they are very vascular. Okay. Meningioma and Schwannoma are highly vascular.
So then I think it could be, because I'm not going to say that the optic tract or the optic nerve is completely, in our experiments, were completely preserved. But it does seem to be less sensitive to it. So I think that could be an extra safety margin if we did want to approach something like this for the schwannomas.
And if you can target the center of the tumor, you can target the center of the tumor. So could be maybe sufficient.
Yeah, and it could be, especially, the tissue is removed very quickly compared to when we thermally ablate it. So when you thermally ablate it, it can stick around for a long time. The body will remove it very slowly or sort of wall it off with scar tissue. With the approach with the non-thermal approaches, it seems to be removed much more quickly. So that may also be a benefit, but it's something also to look into. One question I had, I'm sort of familiar with animal models for meningioma. Are there good animal models for vestibular schwannomas?
What do you mean by a good mouse model?
Well, something that will let us to begin to explore this in a preclinical sense.
There are mouse models with NF2 loss, with the schwannoma, yes.
Mm-hmm.
Yeah, there are. Maybe Salvo can give his opinion, but they are, yes. But they are very small. They are benign tumors, so it's small, but they are, yes.
Are they genetic modifications?
Genetic modified, yes, with the NF2 gene. Like meningioma, you can have genetic modified NF2 related meningioma, or you can have xenograft or syngenic xenograft, many.
Yes.
But I don't know about the vascularization.
Right.
And it's similar to human.
Yeah.
So maybe Salvo can give his opinion.
Yeah, no, I mean, for the model we've been using, for instance, for Synodus and F2, I know there is a model run by Longcheng Shang, which is a xenograft model. But I think that model is somehow compromised. I don't know how useful it could be in terms of, having a pristine system more than, a xenograph. But that model has been extensively used in terms of meningioma. Is a benign meningioma model. Yeah, but there are others that I'm sure we can expand on this topic as well.
Thanks.
So based on the location of these tumors, and you mentioned that they're not always behind the blood-brain barrier, thinking about these drug delivery applications of focused ultrasound we talked about, is the BBB opening, it's something that would be necessary for any of these NF2 treatment tumors, or we think more this other modes of enhancing drug delivery, be it the thermosensitive liposomes, nanocarriers, that sort of thing?
It's for me, the question.
Yeah, sure. Yeah, for you. Sorry.
I think that meningioma and schwannoma are not inside the brain. They are extraaxial tumors. And I think that it's not inside the blood-brain barrier. So there are many other barriers with the meninges. I don't know exactly. I'm not totally expert in this field. But I'm not sure that you need to open the blood-brain barrier for treating meningioma and schwannoma. Maybe it's easier. And when you have a patient with multiple growing meningioma on one hemisphere, if you can target the external carotid artery, then you can apply ultrasound and you can treat many meningiomas, for example. But I'm not sure that the blood-brain barrier opening is a big deal for NF2.
Okay.
Yeah. Well, Nathan, you want to comment?
Yeah, just briefly. A couple of things that we've seen in our preclinical work with, at least with the animal models for brain tumors, where they don't have an intact blood-brain barrier, we still enhance drugs to those tumors as well, so we can potentially get more drugs in. It also, thinking about Avastin, depending on where the Avastin is acting, there's a way to do drug delivery that people talk about called sonoporation, where during the ultrasound pulse, you open up pores in cells and you can get drugs in that way. So we might be able to actually enhance the delivery of Avastin to the vasculature in these tumors directly. And there are barriers getting drugs in around nerves, similar to blood-brain barrier. So if the action of Avastin is to try to prevent the growth of blood vessels by getting the drug outside, we might be able to help prevent the spread of the tumors by getting Avastin to areas where it's currently not reaching. So I think there are opportunities, even if it's outside the brain, technically, but it would not be a BBB opening type of approach.
So this is a question to any of you after hearing all these presentations and this discussion so far. Do you think of the different NF2 tumor types, one rises to the top of a good first place to start exploring the application of focused ultrasound, or how focused ultrasound can play a role at enhancing treatment? Any thoughts?
Tumors have more clinical need than others?
Yeah, I would say meningioma, some large meningioma or growing meningioma first, and explore large vestibular schwannoma, how to debulk, to devascularize. I think it's a must. They are the two targets.
Okay.
Yeah, I would think that the non-thermal ablation debulking strategy that we've discussed could be a good starting point for the meningioma. And I'm really intrigued by this idea of injection through the carotid artery.
External carotid artery only.
Yes, and given that you may not have to, you're not dealing with the blood-brain barrier, potentially highly localized trigger release of encapsulated compound as well in combination. Yeah, I think that would have a real chance to be impactful and effective.
I would start with this.
Yeah, I would start with personally, I think going after the meningioma would be a really, really good starting point.
So drawing on, and I'll ask this one to Arong, drawing on your experience with Thermodox and using focused ultrasound in combination with that, what is the role of the timing of the like when you're delivering or applying the Thermodox versus the ultrasound, and kind of have you optimize that scheme?
So the optimizations have really come from the prior studies, looking at it with Tardox and RFA. And it seems that, I think as Dr. Porter had mentioned, is where they are optimal. So with the Optima study, they found that if you can heat it for more than 45 minutes, it's actually better in terms of the concentrations of the Thermodox. So what we do for our study is we give the Thermodox first over 30 minutes, and then we concurrently start the heating process. And the process is to be heated for at least 45 minutes. The initial phase 1 study that we have is currently with ablation. That was the way it was developed primarily for regulatory needs. And then the subsequent study that's currently being worked on right now is with hyperthermia. So the ablation typically has lasted anywhere between 2 to 3 hours, just based on how much heat has to be treated in order to do the volume ablations. But with the next trial that's currently in development with hypothermia, the plan is to heat for at least 1 hour, a maximum of at least a minimum of 45 minutes, but up to 1 hour of heating at the 40 to 45 degrees Celsius, which we think is the optimal time frame needed for the Thermodox to be effective. I think someone asked about like what's the difference between the heating mechanisms between microwave heating or between RFA, and why HIFU. And I think, you know, in terms of the advantages of HIFU is that the image guidance that's associated with it. So microwave heating is really superficial, which is effective for like the superficial breast cancers, but for our tumors that are located, that are deep and located within, that's not achievable through microwave heating. Same thing with RFA, you're limited by the amount of heating that's around the probe. And again, there's not image associated. So I think the advantages of HIFU is a large volume heating, as well as image guidance, which really shows you what you're heating and where you're heating it.
Yeah, so I have a question for Nathan here. You know, when you've discussed, or you mentioned in your presentation, that thermal ablation in the brain can be challenging unless you're in like centrally located, deeper tumors. But if you're heating, let's say, just to 41, 42 degrees Celsius, which Thermodox can take advantage of, does that concern for meningioma, which is going to be closer to the surface or at the surface, is that possible? Is that a concern, especially if you're heating for, as Aran had just mentioned, heating for tens of minutes? Would that potentially be a concern?
Yeah, there are people looking at doing hyperthermia in the brain, but I'm not super optimistic about it. That, you know, what the brain is very highly perfused compared to the bone.
Yeah.
And so if you're heating for a long time, the heat is getting dragged away from the focus in the brain, but it's building up in the bone.
Yeah.
So I think it could be an issue. I would be interested in sort of looking at whether you can get away with doing, you know, short exposures repeatedly. So if you know, if you could heat it up to 43 degrees for a short amount of time and dump some drug, and then let things cool back down and then repeat it again, if the drug is circulating long enough, I think that you might be able to enhance delivery that way. But I'm not as familiar with the literature on Thermodox or similar stuff. And so I would be interested in doing some experiments looking at short heating to have a drug release and, you know, take advantage of the circulation time of these drugs, or the fact that they're building up via the EPR effect. And maybe we can, you know, if we could divvy the heating up over short exposures and get a similar effect or not, or do you need to have this long continuous heating?
I think with the local administration that Michelle had, the more local administration that Michelle had mentioned, I think it's possible to do it in intervals. I think you could, given that with the Thermodox, just from our own experience, you can trigger 50% of the drug release in less than a minute. You know, you can get 50% out of doxorubicin in on the order of 40 or 45 seconds of heating. And so if you're able to do a local injection over a span of 1 or 2 minutes and apply heating during that time period, I think there's a potential for success. We won't know until we actually try it, but that might be a really viable option. Michel, what do you think about?
Yeah, I think very good. Yes, totally agree with you. Yeah. Just a remark from Brad Welling from NGH is online, and he says that in NF2 patients, some patients will present with subcutaneous schwannoma. So it's one possibility to test the effect on the IFU on schwannoma using subcutaneous schwannoma. So it's not, there is nothing with the skull, but it could be a starting point with schwannoma.
So for the drug treatments, or for, say, when using Avastin to treat patients, how often is the drug given to the patients? In terms of frequency?
It's at the beginning, it's half dosage compared to cancer treatment, and every 2 weeks.
Okay.
It works. It means if it stabilizes the tumor growth or improving, then it's every 3 weeks. And then if it works after 6 months, we need 6 months to evaluate, it's every 4 weeks. And we have patients under bevacizumab for now more than 10 years. So it's why if we can reduce the dosage, it's very good, because it's a long-term toxicity, you know.
And in terms of thinking about just the feasibility of something like this, would it be feasible or practical for patients to have the drug treatment combined with something like focused ultrasound then at the beginning, say every couple of weeks? Is that something that could be done?
Yeah, I think so.
Yeah. Let's see if we I guess while we're waiting for some other questions. Well, here's actually an interesting question, thinking about children in particular. So another exciting aspect of focused ultrasound is the potential of eliminating or reducing radiation, which of course for children has long-term effects. So do we think that if we're able to more effectively target these drug therapies using something like focused ultrasound, that may reduce the need for radiation or eliminate the need for radiation?
I mean, I think that's kind of our dream, right? So, the hopes is eventually if you can target these tumors either with better drugs or with better therapy, that you can limit our current toxic therapy that we're doing, including chemotherapy, certain surgeries, and radiotherapy. There are trials looking at HIFU in combination with radiotherapy because it seems to also potentiate radiotherapy, and that may be able to reduce the total dose of RT. But I mean, obviously our hopes is that, could HIFU be used as a substitution for radiation, for surgery, for other types of toxic chemotherapies in many pediatric and adult malignancies?
There's a question about the types of drugs that would be possible for this enhanced delivery with focused ultrasound. What are the limitations in terms of when you're picking a drug to use with focused ultrasound?
Well, when we're modifying the vasculature, it's pretty neutral. So we can, so far they've been able to deliver everything they've tried. I think Tyrone would be a good person to talk about what drugs are amenable to thermosensitive liposomes or other types of drug release.
Yeah, if you're talking about an unencapsulated drug, as Nathan has mentioned and covered in his overview, it's pretty much limitless. There of course is a question of how much of the drug actually gets into the tissue and to what extent it penetrates, and so what is the sort of intrastitial or intratumoral dose? Can you actually achieve an effective dose? That can depend upon the physical chemical properties of the drug. And so that would be a determining factor, probably along with potential for adverse effects. In terms of packaging, biologics tends to be much more difficult and challenging to put into any nanoparticle. That's the holy grail. Whoever figures that out in an efficient manner that can be scaled up is going to be a gazillionaire. Hopefully I'll be one of the first, but it's very, very challenging to get biologics, whether it's antibodies, proteins, virus. It can be difficult to get them packaged into a nano carrier. I also want to respond just real quick to the radiation question. As Eran had mentioned, there are some ongoing studies combining ultrasound as an anti-vascular approach with radiation that seems to work quite well. The Sunnybrook team, University of Toronto is doing that. And once again, in partnership with Nathan, we've actually explored that idea in the brain. It actually does work really well. In combination, there's a synergistic effect, and you can dramatically reduce the radiation dose that's required in combination with ultrasound in these microbubbles. So there's a lot of potential that's there. It's in the early stages of being explored in the brain. As far as I know, the group that's in Toronto has been predominantly extracranial in cancers and tumors outside of the brain, predominantly, and they've had success. It's in early stages of exploration in the brain, but the results are very promising and compelling at this point.
Great. I wanted to make sure that we have time for just all of you to opine a little bit about then where you see, us taking this, for starting this collaboration between these two fields, where we'd like to go next, if you have any thoughts. Even Salvo, if you have any thoughts.
I guess this is open, and I like the discussion. What I would like to see, maybe we can follow up also with all the participants to capture their ideas and points of collaborations. So moving forward, what I would love to see is proposals maybe, or some advanced ideas of operation expert panel, the experts on focused ultrasounds with practical application of the technology. So I'm open, and I know also Focused Ultrasound Foundation is open to listen and to explore avenues of applying this technology. So let's see, maybe in the next few weeks we'll receive a lot of feedback, but I already see that there are quite a few areas where we can start some projects. So I'm really glad.
We have like a preclinical system for histotripsy and ablation. It's an ultrasound guided model system. I think we can use, we've been looking at it in a neuroblastoma model right now with immunotherapy, but I think there are other ways we can think about looking at it in combination with drug in the animal models. Some of the things that I think the system is so flexible, we can think about it in many ways. And I think Michelle had mentioned some of like the primary targets of tumor types in NF2 that we can think about. Many of these are ongoing to, ultimately would, get resected in a clinical setting. Could we think about, using focused ultrasound in even a clinical setting for patients that are ultimately going to be resected, to see whether or not we don't know how it's going to affect peripheral nerves and what it does to the histology. And so I think there's an opportunity there in patients that are already going to get resection to be able to look at this even in a clinical setting.
Like phase zero. Phase zero.
Mm-hmm.
Yeah, that's a good point.
Yeah, the idea of a localized drug administration really piques my interest. I think I've made that pretty clear earlier, but also an idea of combining this microbubble disruption of blood flow, so this anti-vascular effect that could lead to localized ischemia that Nathan had mentioned earlier, we've explored as well with bevacizumab, right? So that's going to mitigate or suppress new vascularization. And so you could potentially disrupt blood flow, but also suppress any new blood vessels that might be formed or created. And that combination could be, potentially even more effective. And maybe even work more quickly, because the antivascular effect is, happens within hours from what we've seen.
Yeah. Yes, I remember a talk. I gave a talk 10 years ago at the CTF. It was a brainstorming on NF2. And I remember presenting one idea of embolization of meningioma using particle with doxorubicin to have both ischemia and drug diffusion. So it's exactly what you can do now. So it's
so
I think it's
an interesting idea. So it is possible. I don't know what the drug loading, I don't recall what the drug loading efficiency is, but you can actually take the fluorocarbon droplets I had mentioned earlier. You can make them a little bit larger. And actually this is being done by Joe Bull at Tulane for hepatocellular carcinoma. It's a chemo embolization technique that he uses. Yeah. And so he's loading the drug, if I recall, onto his particles before vaporization. And then the bubbles that are formed are quite large. They do block blood flow, and then concurrently they release the drug. He's having some, the results look positive. I have never seen that tried in the brain. I do know that transarterial chemoembolization is one of the strategies for treating HCC, and that's why I think he started there. I think that's why he started there, but I don't think I've ever seen it tried in the brain.
I think one of the things that interests me, right now, if I would be interested in looking at a meningioma model and looking to see if we can enhance the efficacy of Avastin with post-ultrasound with microbubbles. And because that's something that we could actually go to patients today with current technology.
Just a point. Bevacizumab is efficient for vestibular schwannoma.
Oh, that's right. Oh, yeah. Okay. Yeah. I see.
We are looking for other drugs. So,
but we could. The same comment would apply for the schwannoma also.
Schwannoma, yes. Definitively. For schwannoma, it's bevacizumab. For meningioma, it's ongoing.
Oh, it's ongoing. Okay.
But yeah, I would be interested to see, because there is an intriguing study in a rat glioma model where they did improve efficacy of Avastin with post-ultrasound BBB opening type pulses. So I was kind of surprised because I thought Avastin acted on the blood vessels, and so getting drug outside of the blood vessels surprised me that helped, and so. Because interesting. I would be interested in looking at that, and then also pursuing if there are good models, or maybe with meningioma model, to start looking at these ablation with microbubbles to see if we can debulk some of these tumors and avoid surgery.
Well, I think we're coming up on the end of our time. This has really been a fascinating discussion, and so I thank you all for participating. And we definitely look forward to continued engagement between the Focused Ultrasound and NF communities. And as Salva mentioned, the Children's Tumor Foundation and the Focused Ultrasound Foundation really want to find more ways to work together to encourage and support collaborations that we hope will bring new treatments to patients who need them. So to everyone, this concludes our webinar today. I apologize, there may have been a few questions we weren't able to answer. If you'd like to follow up with us via our website, fussfoundation.org, or email us at info@fussfoundation.org, we'll make sure to get those questions answered. And thank you all for joining us, and please stay tuned to our newsletter and website for invitations to future webinars. And you will also be receiving a recording to this webinar probably about tomorrow, I think. So have a great day, everyone. Thanks.
Thank you.
Bye.
Thank you.
Bye-bye.